So welcome everybody to our first and last hot seat session from RSNA case collection for 2023. I'm very excited to bring this session to you. Our sessions at the annual meeting were among the top 10 most attended sessions. So hopefully you'll enjoy the cases here. I have all of our 10 deputy editors online, plus our trainee editorial board team members who will be introducing our deputy editors. And we will show you some really interesting cases, and I hope you enjoy them. And with that, I'll hand the baton over to our trainee editorial team members to introduce our first speaker, and we'll get going.
Hi, everyone. My name is Sophie Washer. I'm a musculoskeletal radiology fellow at NYU. It is my pleasure to introduce our first speaker, Dr. Kumaravel, who is the musculoskeletal deputy editor and assistant professor of radiology and orthopedics at UT Houston. He's going to show us some great MSK cases.
Thank you very much, Sophie. Thanks again. And welcome to the case collection to everybody. And we're going to start off with a couple of cases on the musculoskeletal side. The intention is to get you to think about these cases as we go through. And imagine that you're going through this case in your reporting file. What would be interesting to you, and how do we go about this? Let's go to the next slide. Here's the first case. And here's a patient presenting with left anterior lateral ankle pain after an eversion injury, and think about what could be the possibility. What are the diagnostic choices that could have happened in this case? And that's basically what you're showing you here. And then go to the next slide again. And here are some more projections. A slightly more ankle mortise view and a lateral view of the ankle as well. Give you a few seconds to think about what could be a patient presenting with an ankle pain, and more of an eversion mechanism in this case, and what are the possibility. You can go to the next image again, please. Here are some axial images from selected MRI slices across here. You got a T2 weighted image and another non-fat saturated T2 image. My suggestion to you would be to think about what level do you think these images are taken at. One is at the tibial level, the other one further down, a little bit further down at the talar margin as such, and think about what could be the cause why this patient's having pain. Let's go to the next image again. And again, a couple more images again, just this time again, highlighting at the level where you think could be the reason for the pathology. Please do pay some attention towards the ligamentous components of it and think about what could be the cause for this patient's pain. Again, the T2 weighted non-fat saturated images is what we got here. Next one again, please. And here is the more fat saturated image drawing your attention to what could be the potential reason why this patient's got pain. And then the next image, please. And so what is the potential diagnosis for this particular patient? Do you think it's an occult fracture? Do you think it's a syndesmotic ligament injury? Do you think it's a low ankle sprain or a soft tissue contusion? Let's trigger the pulse. Go to the next slide, please. And again, I hope you have your little devices to go along with it. And we have these polleve.com/RCC. And then if you go back to the last slide for a second so that we can get a choice of what are we looking at. We do have some radiographs across here. And then we do have some MRI axial images highlighting the pathology. All right, go to the next. And let's see what we have as choices now. A bit of smattering around there. Most people going in for syndesmotic ligament injury, and some thinking about maybe it could be low ankle sprain that we're dealing with, and a small number thinking about occult fractures. We'll give another couple of seconds for you to think about what are the potential. And again, there are no wrong answers. This is musculoskeletal imaging. It's easy and fun. All right, a little bit of toss up there between occult and low ankle sprain. All right, let's thanks for playing, and let's go to the next image again. And so this is definitely a syndesmotic ligament injury. Kudos to everybody who got it right. No, majority of the people got it right over there. So what are we looking for? Just to, again, go to the next slide again, please. And the components we're looking for is obviously marrying up the clinical findings first. You really want to think about where the pain's coming from, taking as much of the information as available to you. And if you're in my kind of practice, all you get is pain, but in this case, we give you more information than that. There is the images that are most pertinent are at the distal tibiofibular level. You can see T2 bright signal highlighted by the arrows. It tells you that that's where the action is happening. You have a disruption of the anterior inferior tibiofibular ligament. And obviously with the squeeze test, it also tells you it's going to be painful. A widened tibiofibular space is also another component that you can actually look at this. MRI demonstrates there's also a full thickness tear of these ligaments across there, and the tear is extending partially through the interosseous membrane region and almost all the way down to the posterior inferior tibiofemoral ligament. So this is something that would need a surgical fixation. Thank you for playing with that case. Go to the next one, please. Here's case 2. And here's the first image again, 58-year-old male patient. We got a history of chronic arthritic pain, but unfortunately had a recent fall. And you were thinking about the patient present to the ED, and you're wondering, what could be the cause for this patient's pain? Is this something that has actually changed in presentation? A couple of axial images. One is a bone window, another one is a soft tissue window. Just to give you an orientation, we are all the way at the C1, C2 level. All right, next image, please. Here is a sagittal projection demonstrating in bony windows. Give you a few seconds to look at. And the next slide, please. We got a soft tissue window and a coronal multiplanar reformatted image as well, just to highlight the features that could be potentially causing pain in this patient. Go to the next one again, please. And we also found that the patient had other things going on, and here is in the patient jacket. We found there's a couple of x-rays on the hand that's coming through, and here's a focused view on the right side and a larger view of the hand on the left side of the image. And pay attention to what you think could be the soft tissue and the bony changes that's going on there. And the next image, please. So what could be the diagnosis? And if you want to trigger the poll, go to the next slide and we'll come back to this again. Come back again. So what could be the potential diagnosis? Do you think you're dealing with amyloid arthropathy? Is it just spondyloregular degenerative joint disease? Is that what you're going to go say on your report? Or would you say this is cervical spine gout? Or do you think this could be rheumatoid arthritis? Again, we've got a smattering of all the images out here, although a little bit smaller size. But now think about what you can correlate between the radiographic features of the hand and also what is available in the cervical spine as such. All right, let's go to the next slide and see what the results are. So we got a pretty dominant number of people, still well getting close by. 50% so far think it's cervical spine gout. There's some thinking maybe this is rheumatoid arthritis. No one's gone for the question about degenerative joint disease, which is great because there's a little bit more than that, correct? And so what else could be the choice now? So make up your mind. If you want to change your results, go for it. We'll give you another few more seconds. Sorry, I don't have music playing in the background. Maybe we need to work on that. All right, another couple of seconds. Anybody wants to change your mind or add any more information? All right, okay. So dominant number of people going, 58% of you going for cervical spine gap. Let's go to the next slide. 60% now. All right, the answer is absolutely correct. It is the cervical spine gout. And when you look at these different features, go to the next slide, please. So what you're trying to do is to understand that we certainly showed you some marginal erosions in the hand. That gives away a big portion of the diagnosis. Is juxta-articular, erosions along with tophi. Now, if you come back to the cervical spine itself, you're going to see that the erosive changes, crystalline deposits, and which are much likely tophi. We did not do any, I mean, like here's in this particular case, the authors did not show you anything with dual energy scan, and that's another thing we can think about. And think about the juxta-articular well-defined erosive changes that's happening along here. And with the hand, it was a good idea to look at the soft tissue changes and also tophi. So this is a case of cervical spine gout. Thank you very much for listening to these cases and looking at these cases. I hope it whets your appetite and think about dwelling a little bit more in the RCC. And thank you again for being the audience here. Next slide, please. Thank you.
Thank you so much for those great cases. Our next speaker is Dr. Kush Desai. He'll be showing us some wonderful interventional radiology cases. He is a professor at Northwestern University Medical Center.
Thanks. Okay, we'll go to the next slide. Keep moving. It's the first case. This is a 64-year-old male with history of epiglottic carcinoma 2 years prior. Who presents with a new right lower lobe pulmonary nodule. CT guided biopsy is requested to evaluate for metastatic disease or primary lung cancer. And, you know, with these kinds of things with IR, you know, we're thinking about how we want to position the patient, potential things we need to talk to the patient about in terms of informed consent. So while we're doing this biopsy with adequate sampling, we notice that there's a small post-procedural pneumothorax, certainly nothing surprising there, probably a little bit of COPD emphysema here. Patient remains asymptomatic. So we pull the needle out. As the patient is transferred off, the table becomes unresponsive. Rapid response team comes in, diagnoses the patient with an acute stroke, and they get a head CT. Let's go to the next slide. But before they get a head CT, we're looking a little bit closer at the CT images of the chest. Take a close look, not just at the lung, but at the heart vascular structures. Let me go to the next slide, please. And this is what the head CT shows. I'm no neuroradiologist, but even I can see this. And let's go to the next slide. So what's the diagnosis? Is this a systemic air embolism? And while we're thinking about the diagnostic possibilities, we need to think about also how we would manage it. Is this a systemic air embolism? Is this thromboembolic phenomena resulting from withholding anticoagulants prior to the biopsy, something we deal with every day? Is this a venous air embolism? And as you guys are making the choices, you have to take a look. You have both head CT images and you have the chest images, although I believe one of the chest images we need is not quite on this picture, but you did see the head CT image should certainly tell you what's going on. Let's go to the next slide to see what our responses are. And as you're answering, think about how something like this could happen and whether it could go to the right heart or the left heart. Think about the flow of blood. That should really inform your choice. Another second or two. And also think about how you want to manage this. Okay, go to the next slide, please. Seem to have guided people in the right direction. So the diagnosis indeed is systemic air embolism. And this, even with the best technique, it can happen. It's very peripheral nodule. And it's just reality. You sometimes just don't see the pulmonary vasculature that you introduce a little bit of air during your needle exchanges, and that can go into the pulmonary vein. Then, of course, become a systemic air embolism. Let's go to the next slide. So time is of the essence. Administer 100% oxygen. That's sort of the obvious choice, but you need to place these patients in left lateral decubitus to prevent an airlock in the right ventricular outflow tract. If you get an airlock, then you will have complete circulatory collapse. So it's very important to move very quickly here and administer 100% oxygen so that the air dissipates out by re-equilibration of the gases within the patient. Next slide. Moving on to the next case. 43-year-old male, colorectal cancer, metastatic to liver, peritoneum, status post HIPEC surgery, which is a hyperthermic intraperitoneal chemotherapy administration, complicated by multiple bowel fistulas, colocutaneous and colovesicular fistulas, who presents following a syncopal episode with severe abdominal pain, melanotic stool, and his colostomy and hematochezia, in which you have a couple images right here of a CT angiogram, and you can see contrast that's accumulating in bone windows, or bone or vascular windows in the middle image, and then probably a little bit delayed in the rightmost axial image. We'll go to the next slide. And here's an angiogram. And you can see here that there's some collection of, this is a digital subtraction angiogram. The iliac artery, you can see there's a collection of contrast. We'll go to one more slide forward. And you can see on the right is the pre and the left is the post here. And an intervention took place in the midst of it. And let's go to the next slide. So also, again, thinking about what you would do based on what you think the diagnosis is. Is this a variceal hemorrhage? Is this a diverticular bleed? Is this an iliac enteric fistula? Or is this an angiodysplasia? And again, think about what this patient had, as well as what the most likely diagnosis is based on what they had. I'll give you a few seconds. And how you would want to manage this. This is very challenging. I actually managed this very case about a few hours ago, slightly different structures, but same idea and same therapeutic consideration. Next slide. Excellent. All right, great. Let's go to the next slide. Indeed, this is an iliac enteric fistula. It's not an angiodysplasia. This patient's had HIPEC surgery. They have risk of multiple fistulas, colovesicular, colocutaneous, colovaginal. I mean, it could be anywhere. And this is an iliac enteric fistula. I actually just managed an iliac ureteral fistula about 2 hours ago. Next slide. This can be rapidly fatal just because of the laws of physics. You're going from a high pressure to a low pressure system, and blood accumulates very fast in the capacious GI tract. Embolization, usually the first step. I believe stent graft is used in the case that's shown here. You do need to be careful with stent grafts because if the stent graft is in close proximity to the fecal stream, say it's a blowout, you run a very high risk of that stent becoming infected, which is a surgical nightmare, if not outright fatal. So that there is a risk of septicemia with that. So there are a couple ways to manage this: embolization, exclusion with stent graft. It's going to depend on where the lesion is. Hope you found these interesting, and we'll go on to the next set of cases.
Good afternoon, everyone. I'm Dr. Vicini from Sapienza, University of Rome. I am pleased to introduce Dr. Yiming, Associate Professor of Radiology at New York University, who is about to present some great breast imaging cases. Please, Dr. Gao.
Thank you so much for that introduction. And I just want to say thank you for all these wonderful cases. It's always sobering, look at other subspecialties and see how urgent other potential clinical situations can be. And our breast cases in general are not as urgent, so I'm very grateful. So let's move on to case number one. So case number one is a 67-year-old woman with no significant medical history who presents with a palpable mass in the left breast as indicated by the BB marker in the superior aspect of her left breast. And we're showing here bilateral MLO views of mammography. And we can move on to the next slide. I think this is not quite an eye test. As you can see, there are multiple bilateral findings that are both palpable as well as clinically not palpable. Next slide. So bilateral breast ultrasounds are performed and representative findings are demonstrated here. Next slide. Additional representative findings. I think ultrasound does offer a lot of morphologic details in addition to mammography. As you look at findings in terms of their marginal characteristics and internal echoes and associated vascularity. Next slide, please. So we can trigger the poll and come back to this slide. So what is the diagnosis? Is this metastatic melanoma to the breast? Is that bilateral fibroadenomas? Is this primary breast lymphoma? Or is this bilateral cysts? I think we can see the poll potentially. Very interesting. So just thinking back to the patient, right? She is in her 60s. Her mass was enlarging, if you recall. And looking at the ultrasound does give you some sense of whether those actually resembled more benign appearing masses versus more malignant masses. And I like the trend of the poll. Hopefully my information is helpful. So yes, we can move on. So yeah, so the final diagnosis is metastatic melanoma to the breast, and we can move on to the next slide. So metastatic disease to the breast typically manifest as round circumscribed masses, and they can be unilateral, but they can also be multiple bilateral, in which case it's a rare malignant mimicker of the typically benign multiple bilateral circumscribed masses that we talk about on mammography, typically cysts or fibroadenomas. But as you can see on ultrasound, these indeed are more irregular appearing masses. And most commonly, extramammary primaries that metastasize to the breast include melanomas, secondary lymphomas, as opposed to primary lymphomas, which typically is unifocal, lung, ovarian sarcoma, and interestingly, in men, the most common primary to go to the breast is prostate cancer. And in this particular patient, usually we would already have a known history of other primary, but in this case, metastatic disease was biopsied in order to clinch the primary diagnosis. So that's this case. We can go ahead and move on to the next case. So case number 2 is a 30-year-old woman who presents with bilateral, slow-growing, palpable masses in her subareolar regions. And pertinent negatives, she has no history of trauma. She has no indication of infection. And here you're seeing mammography in MLO and CC views. And you can go ahead to the next slide. So targeted ultrasound is performed in the regions of concern as per clinical standards. And you can see bilaterally, we are showing sonographic findings that appear somewhat similar. And this corresponds exactly to what she is feeling in her breast. And we can go on to the next slide and trigger the poll. Thank you. So what is the diagnosis? Number one is invasive cancer. Number two is diabetic mastopathy. Number three is breast abscess, remembering the pertinent negatives. And finally, fat necrosis, again, pertinent negatives. And we can move on. Excellent. So again, thinking, invasive cancer is probably the most common thing we think about, but this individual is very young. This is bilateral symmetric findings. She's never had trauma, no infection. So I think most people are really on the right track. So let's move on to the final diagnosis. So yes, this is a case of diabetic mastopathy. And next slide. So diabetic mastopathy is also known as inflammatory lymphocytic mastitis, characterized by lymphocytic infiltrates in periductal, perilobular, and perivascular distribution. And because of a fibrotic mass, like fibrotic proliferation in the breast, on ultrasound, you typically would see shadowing masses. And this could be mammographically occult. And again, this is another entity that could be unilateral, but can be bilateral. And can also be seen in many other inflammatory arthropathies, including systemic lupus erythematosus. And that concludes the breast cases. I hope you enjoyed it. Moving on.
Thank you very much, Dr. Gao. Our next speaker is Dr. Christopher Walker, Professor of Radiology at the University of Kansas, who will be presenting some interesting chest radiology cases. Please, Dr. Walker.
Thank you for that introduction. Let's go to the first case. So this is case one. This is a 41-year-old man who presents with chest pain and palpitations. So we have 3 images from a cardiac CTA, the level of the pulmonary trunk, and a little bit lower going down to the aortic root. Next slide. So what is the most likely diagnosis? We can trigger the poll. Is this an anomalous origin of the left coronary artery from the pulmonary artery, also known as L-kappa, a coronary artery fistula, vasculitis, or a case of Kawasaki disease? I'll give you guys a few seconds to kind of think about that and look at the images. Let's go to the poll. So most people are between L-kappa and a coronary artery fistula. And let's go to the next slide. So this is a case of L-kappa, or anomalous origin of the left coronary artery from the pulmonary artery. And let's go to the next slide. And this is really important to differentiate this disease from a coronary fistula to the pulmonary artery. So with L-kappa, the most important distinction is going to have the fact that you do not have a normal left coronary artery arising from the left sinus of Valsalva. And so in this case, you can see the left coronary artery arises from the left aspect of the pulmonary trunk, and you're going to get retrograde flow. This disease is also known as Bland-White-Garland syndrome, and most of the time it's going to manifest in infancy, unless people have enough collaterals forming between the right and left coronary arteries, at which point you may actually see these people first presenting in adulthood. Let's go to case number 2. So this is a 93-year-old woman who presents with worsening dyspnea. We have 2 images, an axial contrast enhanced chest CT and a coronal contrast enhanced chest CT, kind of centered at the level of the heart. Next slide. So what is the diagnosis? Is this a sinus of Valsalva aneurysm, a membranous ventricular septal aneurysm, a muscular intraventricular septal aneurysm, or a mitral aortic intravalvular fibrosa pseudoaneurysm? And so take a close look at the 3 different images. This is something unusual. Probably see it maybe once every couple of years. And so if it's the first time you see it, you probably aren't sure what this is, but let's go to the next slide. So it looks like we're between a membranous ventricular septal aneurysm and a mitral aortic intravalvular fibrosis pseudoaneurysm. Let's go to the next slide. And so this is a case of a membranous ventricular septal aneurysm. So if you remember the anatomy of the intraventricular septum, the membranous portion is the thin portion that's closest to the valve, and the muscular portion is where the muscle is, kind of more distally towards the apex. Let's go to the next slide. And so in this case, you can see this aneurysm bulging in the region of the membranous intraventricular septum. And these are usually incidental findings. Most of the time, the patients are asymptomatic. About 20% of patients will have a VSD that's associated with this condition. And if these become very, very large, they can actually result in right ventricular obstruction or in arrhythmia. But usually you're just going to find these incidentally on scans performed for another reason. Thank you.
Hi, everyone. My name is Richa Patel. I'm a body imaging fellow at Stanford University, and I have the great pleasure of introducing Dr. Douglas Katz. He's Vice Chair of Research and Professor of Radiology at NYU, and he's going to be presenting some interesting gastrointestinal cases for us.
Hi, thanks, Richa. I actually did my fellowship at Stanford a long time ago, so it's great to be introduced by you. I don't have a camera. I'm actually at work doing a late shift. So if I could have the next slide, please. And before I forget, let me thank Mariam Moshiri for all her work over the years on the case collection, and Valerie, and then more recently Drew. It's been a pleasure to be part of the team. So our first case is a 52-year-old woman who presented with occasional epigastric pain, and we have 2 ultrasound images. You can see there is some flow, at least the periphery of this, on the Doppler image. And then the next slide, please, shows CT and non-contrast on the left. We see clear metasteatosis of the liver. We have a ovoid mass that's abutting, but as you can note, there's mass effect on the left adrenal, so this is not of adrenal origin, but it's sort of paraadrenal, and it's quite vascular on the subsequent IV contrast enhanced image. Next slide, please. And then the coronal and sagittal representative images showing a little bit of heterogeneity, a little bit of lobulation of this ovoid interesting mass. Next slide, please. And so is this unicentric retroperitoneal Castleman's disease? It's been also referred to as angiofollicular lymph node hyperplasia. Is this retroperitoneal lymphoma? Is this a retroperitoneal liposarcoma or a retroperitoneal schwannoma? And we see the representative images here. So we can go to the poll everywhere slide. People a minute to go ahead and vote. Again, we did not get copyright approval for the Jeopardy music. Sorry about that, as Nick's alluded to. We're seeing a preference for Castleman's disease here, with a substantial minority seeing this, thinking this could be a retroperitoneal schwannoma, which is certainly a reasonable thought. Nobody going for lymphoma or liposarcoma. All right, so let's go ahead to the next slide with the diagnosis. And this is, in fact, biopsy-proven unicentric retroperitoneal Castleman's disease. We can go to the brief discussion slide, or there's the image slide with the diagnosis, and the next slide. So this can be incidental, occasionally symptomatic, and Castleman's disease is a very, very interesting condition. The vast majority of this is benign. A small subset, at least based on the older literature, can be more aggressive. And it can occur in a variety of locations in the body. So at least in the retroperitoneum, the differential considerations for a vascular focal mass can include a neuroendocrine tumor, paraganglioma, a vascular metastasis in the right clinical setting, neural tumors, and sarcomas, amongst other possibilities. Lymphoma, nobody liked that, and I agree, it's not usually this vascular. Okay, let's go on to case number 2. This is really a crazy, crazy case. I had never seen this before in my career, sort of blown away when this came through a few months ago. This is a 72-year-old. Now, you know, sometimes history is not particularly specific, and this is a flavor, a variant of something we see every once in a while, fairly rare. This is really unbelievable case, but you can actually kind of make the diagnosis, believe it or not, from the history, forgetting the imaging. 72-year-old man presented with 4 days of increasingly severe left lower quadrant pain, rating to the inguinal region in the lower back. Associated symptoms including nausea, vomiting, decreased appetite without bowel movements for 3 days, and substantial scrotal enlargement for 1 day. Importantly, he had had intermittent right upper quadrant pain for many years, and a minor swelling with a lump in his left inguinal region for over 10 years. So you put that all together, look at these representative images through the upper to mid abdomen on this IV-enhanced CT. There are several findings. And if we can go now to the next image, which shows the lower abdomen and pelvis, ignore his spondylolysis, by the way. And you can see some interesting things here as well. Now, if we can go on, I think there's one more set of images. You have one image with a coronal image showing the anatomy. Okay, and let's go on to the differential diagnosis slide. So is this perforated diverticulitis? Is this gallstone ileus? Or is this something the authors have labeled as perforated gallstone coleus? Now, I thought coleus was a plant, and I thought this was a mistake, but they said, no, we want to include in the differential something they're calling gallstone coleus. So let's go on to the poll everywhere slide. Okay. So again, we want the most specific answer here. Wait another minute. Okay. All right, let's go on to the answer slide. Next slide, please. And in fact, this is something, again, the authors are coining this term for the first time ever to my knowledge, perforated gallstone coleus. Let's go on to the discussion slide, or there's the diagnosis. So this unique contribution from Dr. Mindy Haro at Einstein in Philadelphia and her colleagues, to my knowledge, has never been reported before up until this case. So there are a variety of pathologic points at which a gallstone or enterolith, if it's an enterolith ileus, can lodge, which when freed into the bowel, such as a tumor or stricture, can then present with gallstone ileus. In this case, it's a colon as the site of obstruction, specifically a hernia. And this is, again, a variant of this, but it makes perfect sense. And in fact, you can actually figure it out from the history, and then the images just prove it. So this is which makes this specialty of ours so special. Even for someone experienced at this point like myself, makes this so incredible a field, and I hope you feel this way as well. So again, it's been a great honor to be involved in this project for several years. Thanks to everybody. Hope you're enjoying this presentation. Let's go on to our next presenter.